And we have check marks across the board. We are
All right.
live on April 26, 2024. I always give the date because technology changes so fast in HCM these days. It's important to know when you're listening. This is, oh, no, we are not on Facebook. We are having a problem. We are on LinkedIn, YouTube, and X, but Facebook did fail. Okay. Sorry, Facebook. You'll have to catch us some other time. So this is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am Lisa Salberg. I am going to be speaking today with Dr. Steve Ommen at Mayo Clinic, who is definitely in Dr. Garb today for those watching the video version. Good morning, Steve. How are you?
I'm good. How are you doing?
I am very good today. Thank you. So we have themes of the month, as many of you know, and the theme of the month for April is about family heart health history and understanding the role of genetic testing. And so we wanted to take a few moments to talk about the familial nature of hypertrophic cardiomyopathy, as well as maybe some of the spectrum disorders. And if we could get some perspective from Dr. Amen on what should we know and what should we be sharing with our families about our HCM diagnosis, and how should families react to that information. So what should they know?
So, I mean, obviously, there's some differences in each families around information sharing, et cetera. So you always have to take that into account. But we think that patients' immediate families should know, and even not just their first degree relatives, but people beyond that should know that hypertrophic cardiomyopathy exists in the family because members of their own family may be impacted by this.
Absolutely. So upon a diagnosis, what we're going to take the clinical aspect out for a second. We're going to
Yep.
assume that the patient has had risk assessment, it's been fully evaluated, and we're going to hope that they've had the opportunity to do so at an HCMA recognized center of excellence. So they've been all worked up, but now we're on that family component. Who should be
Mhm.
screened? When should they be screened? And how should they be screened?
Yeah, so our guidelines have always focused on the first degree relatives. And again, that would be parents, siblings, kids. That doesn't mean that the next shell around that couldn't be screened. It's just not mandated in any guidelines or policies. But our current recommendations are that first degree relatives get screened by one of two methods, either genetic testing or periodic echocardiograms. For adult first degree relatives, we recommend it. Well, so let's talk about genetic testing first. So if the patient and family choose to get genetic testing, and we find an HCM associated gene variant, then we test the first degree relatives against that variant and follow up any positives, and we essentially can reassure negatives that they will not inherit the index patient's condition. But it's all predicated on that index patient having a positive genetic test. If the patient's genetic test comes back as a VUS or a negative genetic test, or they choose not to do genetic screening for some reason, then we switch over to an echo imaging pattern for those individuals. And for the echo surveillance pattern, we recommend that adult first degree relatives get screened at the time of the first patient's diagnosis and every 5 years after that. If you've had a bunch of echoes and you get to 60s or 70s, it's probably okay to quit as long as there's no symptoms. But that would be the general recommendations. And then for children and adolescents, we think adolescents should be screened, and they should be screened every 1 to 2 years. And then children under the age of 10 is somewhat more nuanced. There's nothing wrong with screening a kid. But even amongst gene positive kids, only about 5% of them show hypertrophy under the age of 10. So it's just having to know that when you go in, but it can be reassuring for patients and families to start that screening early. Certainly, if there's a family history of early onset HCM or early cardiac arrest or positive genetic variants, then we suggest the screening start sooner. In the absence of those kind of things, again, it can start at any point, but it should start no later than the onset of puberty. So you can start earlier, but then kind of once the child starts going through puberty, then they should be entered into regular surveillance at that point.
So is echo screening enough, or should MRI be used in any of these screening protocols?
So echo is what is typically done. You can switch to MRI if for some reason the echo images are equivocal or non-diagnostic, then you might need to use MRI, but it wouldn't be just the first test out of the box.
I get that question a lot. That's why I put it out there. Why don't we just all get MRIs all the time? I'm like, that's a little expensive and a little claustrophobic for some of us.
Well,
So,
and I think, well, and also think about that from a young child's standpoint, getting an echocardiogram where they get to watch a movie while they're having their echo done on a human being talking to them versus being loaded into a
tube.
torpedo tube and hold their breath and lay still is a little bit more challenging to pull off.
Absolutely. So we have a schematic that we basically follow for screening families. I often get asked the question of second-degree family members, aunts and uncles and cousins. You touched on it briefly that they can get screened, but there's no guidelines for that, and thereby sometimes reimbursement can be a little bit tricky in those families. Any recommendations or thoughts for what aunts, uncles, and cousins might want to get screened and how to go about that?
Yeah, I mean, I think that, again, it becomes very easy in a cascade genetic testing environment. So again, if the patient has a gene variant and the patient's mother has a gene variant, well, then the patient's mother's siblings become eligible for screening, and so that becomes kind of rote and automatic if we're doing genetic testing. For the echo surveillance, if there is a second-degree relative, an aunt or an uncle or a cousin who has any cardiac-related symptoms, it's sort of a no-brainer. That's almost not screening. That's being evaluated for your shortness of breath or your chest pain or whatever. That's almost not screening, but they should certainly mention to their teams that there is a family history of hypertrophic cardiomyopathy there. I also have seen many patients who said, yeah, my aunt is really nervous about this. Well, have her get screened because there's a family history of cardiomyopathy. And often just family history of cardiomyopathy can be enough to have that covered. So that's the way I would approach it. Certainly if there's symptoms, it's a no-brainer. If there's no symptoms, then there's ways you can try to say it's because there's a family history of heart disease.
So we do the screening, we look for disease. We look for the presence of hypertrophy, abnormal EKGs. We look for those clinical signals. But what is the meaning from one person to another about what else has happened in their family? If there's a family history of atrial fibrillation in HCM, if there's heart failure, if there's malignant arrhythmias, what is the meaning from one person to another? Is there any?
It's certainly not one for one. You can have people within the same nuclear family have wildly different patterns of hypertrophy and wildly different manifestations of their HCM, to where one has major symptoms and hypertrophy and consequences. The other one has a little bit of hypertrophy and lives a life that you wouldn't know is any different than anyone else, other than the fact that they get echoes periodically. So it's not one for one, but you obviously, if you're within a family, and cardiac arrest is a risk factor, so we're going to always talk about with those factors, there is a tendency for arrhythmias to run in families. But again, it's not one for one, and that's one of the things that when we do diagnose the next member in the family, we make sure we talk about it and say, just because your sister has HCM and now we've diagnosed you with HCM doesn't mean you're a clone of your sister. You may have a completely different pathway than she had. And so, let's make sure that we're addressing you as an individual and treating what's real and preventing what we can prevent.
So you brought up a good point there, that we know that if there's a family history of cardiac arrest and other signs are present in that patient, that may guide a decision to therapy.
Yep.
But is it a guarantee of therapy?
Right. Not necessarily.
Okay. So we've got some clarity on that. So we've screened our siblings, we've screened our parents, we've screened our children, and we now know that we do or do not have an identifiable gene. And for this scenario, let's say we've found a gene. Mm-hmm. Is the presence of the gene itself a guarantee of disease expression?
It's not. So people can be what is, loosely said, a gene carrier, meaning they can have a gene positive status and at no point show left ventricular hypertrophy. We don't know if we did biopsies on those individuals what their cellular function would look like, but they don't have overt evidence of HCM just because you have a positive gene.
So we spoke to Perry Elliott. Oh my goodness, this must be like 2 years ago on an article he published on gene penetrance.
Mm-hmm.
And can you talk a little bit about what we know about penetrance in terms of statistics?
Yeah, I don't have the numbers off the top of my head, but for the audience that's listening, so penetrance is just that, what percentage of patients who have the gene show evidence of the disease, essentially. And I don't have those numbers off the top of my head, Lisa.
So my recollection, it was somewhere in the neighborhood of 80% will show some cardiac involvement at some point in their life, which may not exist until later decades, like 70s and 80s.
Right.
And it doesn't all have to look like the same thing is my very abbreviated version of Perry's very elegant paper.
Yeah.
So if you're listening, Perry, did give you cred there. So I think it's important for people to know that having a gene isn't I have the same disease as my family member has necessarily at that time. They just have the genetic marker and they need to be under surveillance.
Mm-hmm.
And the adult patient under surveillance, that is the every 3 to 5 year check-in with a cardiologist. And I know we've been discussing within the community, should that ever end? Is there a time where we don't have to screen anymore? And then a couple patients pop up in their late 50s, early 60s with a new diagnosis and kind of screw up the agenda again, going, well, guess we can't stop at that age because we found somebody there.
Yeah.
Where's the top number going?
Yeah, I mean, I think it depends on what the history of the echoes is. If they're stone cold normal and they've been screened since they were 35, so they've had 7 normal echoes, I think you can quit. Now, if there's borderline hypertrophy, if there's diastolic dysfunction, if they've got atrial fibrillation and those kind of things, well, then that changes what we're talking about. But if they've had a bunch of echocardiograms every 5 years that are normal and unchanging, then I think it's reasonable to stop when someone hits 70.
70 is a good number. I like 70. It's after that welcome to Medicare exam, and we can figure out what's going on there. So let's talk for a minute about what else we could find in these genetic stories. And I'm specifically thinking of other thick heart muscle genetic diseases like amyloidosis, or in the young families, Dannon's or LAMP2 mutation. Why is it important to know if you have a sarcomeric protein abnormality or one of the mimickers or phenocopies? What's important?
Yeah, I mean, for instance, if you take something like amyloidosis, there's a completely different treatment pathway and drugs available to treat that if they have specific amyloid genetics. They wouldn't be candidates for cardiac myosin inhibitors if they had them. And in fact, none of the other mimics at this point would be eligible for cardiac myosin inhibitor therapy if that's what we found out they had genetically. So it's just important right off the bat that it would slot you towards and or away from certain therapies if we knew that your underlying disease was a different disease process. There's also differences in when you screen kids, like as you said, Dannon's and LAMPs and those kind of things. You're going to age, then maybe you can float the single digit years in some families with HCM. So there's just differences in screening, differences of when it affects individuals, and obviously different therapies that are involved.
The other mimicker that I'll bring up, although it's rare, is Fabry's disease or a GLA mutation.
Yep. So there's specific. So that's a deficiency of an enzyme, and there's enzyme replacement therapy. So again, if we found that they had Fabry's, then again, it opens up a new treatment pathway for those individuals. And that disease in particular can affect kidney function way more than HCM does. It can affect neurologic function. So there are other things that would then be checked if you had one of these other disease entities.
So HCM is kind of the entry point for a lot of people to get into getting their heart screened and going into genetics. But you find out sometimes that it's not exactly what you thought it was.
Yep.
And it's important to know that differential diagnosis. So, among families who don't know their genetic mutation, that can leave some fear or some questioning as to whether they really have HCM or not. So, I prefer to say the results are pathogenic, VUS, or no mutation identified, rather than saying it's negative, because that gives us this
Yep.
perspective that it's nothing's there, but nothing's there doesn't mean that nothing's really there.
Right.
Can you help me make that make sense?
Yeah. I mean, again, so most of the genetic testing that we've done are doing gene panels. So they're looking for specific abnormalities. The specific panels we're looking for are looking at a tiny fraction of the genome that exists. So there may be changes in codes in the DNA that we just haven't identified yet that are lurking, that aren't tested for in those panels. So I think that's fair. The panel did not reveal a known HCM variant is a better way than saying there's no gene abnormalities. I think it's also important because it comes up from a few patients every year, and that is, well, I don't have to screen my family because my gene test was abnormal, or what was normal, didn't identify anything. So that's not technically true for the same reason. For the genes tested, there was nothing there, but that doesn't mean it's not still a potentially hereditary condition in that family.
So you bring to my attention, there's those cases and those people that stick with you and you're like, I wish I could have gotten there differently. There was a member of one of our social media groups who found a VUS and a BAG mutation, and they were living in Europe, and they're like, well, I found my mutation and my daughter doesn't have it, so I don't have to screen anymore. I'm like, whoa,
Yeah.
please roll that back. And this person wanted affirmation that the child was okay, but this didn't really provide it. So they made it fit. They took the square peg and put it in the round hole because it made them feel better. Could you discuss how actionable a VUS is and what it can be used for?
It's not. A VUS is basically almost a non-helpful test result. It should be interpreted as the equivalent of, because you have a VUS, you must use imaging as your screening tool.
That's an excellent point.
Now, occasionally, after another aliquot of years of research, we learned that a certain VUS actually, it does track with more HCM families, and it's been determined through the methodologies that are used to do that this actually is an HCM associated variant. Well, if that's the case, then we can change that family screening algorithm.
But a VUS where no mutation identified does not mean don't screen the family with clinical evaluation.
Correct.
Boom. Underline. Correct. That's our talking point for this meeting. I think that's critically important. Now, families, we know, are unique. We all have our own dysfunctional, functional family.
Mm-hmm.
Do you have any words of wisdom after all of your years in practice about how families deal psychologically with a genetic mutation identification, and any words of wisdom for them as they enter this journey?
Yeah, I mean, this is where it does get down to individual families and individual and cultures that differ across the world for those types of things. There's always been some concern that if you get labeled with something at a young age, you might be treated differently, and therefore your growing up might be different, or those types of things. And I remember when we were looking at this for the 2020 guidelines, we came across some articles where they'd actually studied the psychological impact on children and adolescents of knowing their gene status, and there wasn't a strong signal there that there was harm for knowing that. So I think that the head in the sand doesn't necessarily result in protecting the kids or changing their trajectory in maturation or socialization or those types of things. Again, I hesitate to tell families how to be families, but my bias would be that within a family, people are aware of this condition. You talk about what it is. we talk about how most people with HCM don't have any of the single major consequences. And so just because you have this diagnosis doesn't mean you're going to end up with a transplant or a myectomy or a defibrillator. You may not ever have that. So don't see this as automatic doom and gloom, but awareness of it can keep you safe when other health conditions come up, other procedures are needed, or you start having symptoms, then it results in earlier interventions and treatments for those things.
I think that's a great point. I was an early adopter of gene testing, and I knew my daughter's genetic status when she was only 7. She found out when she was like probably 8 or 9, and she was clinically diagnosed when she was 10. It's just a part of who we are as a family. It's something that's in the background. I think most people would be very surprised to know that I don't go home every night and talk only about hypertrophic cardiomyopathy. We are a normal family who talk about normal things. And yes, we mention our hearts occasionally. It's not the center of our identity. And that's even as a founder of the nonprofit organization, right? So it's a piece of who you are. It's not who you are. And it's a piece of who our kids are, but it's not who they are. So I think those things are critically important to talk about, but there is genetic guilt that can come along with this. And managing genetic guilt is not necessarily something in the cardiology training toolbook, but it's something that you guys have a lot of experience with. Do you have any words of wisdom before I share mine about genetic guilt?
Well, first of all, I mean, it's totally understandable why someone would feel responsible, but they're not. You have no control over which egg is fertilized by which sperm when having a child. Now, if you wanted to get into in vitro fertilization, that's a different realm in the modern era, but that's not accessible to most families from a access to care, cost, all those kind of things. But I mean, I mean, I think you would have more direct insight into this within your family and within the community of people that seek guidance from HCMA.
So I take my lesson from my father, and it was at one of the first HCMA meetings. It was in Parsippany, so that's either year 1 or year 2, because we were only there 2 years. And somebody asked him. Now, he had lost a daughter. His father had died young. His brother had died already, and his sister had it as well. So my father's generation, all 3 kids had HCM. Mm-hmm. One died in a car accident, one had a cardiac arrest at 47, and my dad lived to 73. He buried my sister in 95 when my father wasn't quite 60 yet. So dad went through some stuff, right?
Yep.
And somebody asked him, well, don't you feel guilty? He said, I gave them what I gave them. They lived a life. They were happy. And I'm happy that they were happy. And that was my dad's view. And since then, I repackaged that to, I'll give you 24 hours of genetic guilt just to process it. Sit in the box, be upset about it, say, shit, I wish it was a different situation, and accept the good and the bad, because you are as much to blame for their HCM as you are to blame for their personality, for their smile, for their eyes, for all the things that make them them. You're responsible for that too. So if you're going to take blame, take credit, and in the end, it balances out. This is my theory. Keeps me sane, at least most of the time. Okay, so we don't have our Facebook community with us today, who tends to ask us a lot of questions because of a technical glitch. So we have our LinkedIn, which tends to be more of our professional participants, our physicians, our industry reps, and our YouTube crew, and X, which I'll just continue to call Twitter forever because, it's Twitter. So if there's anybody there who's any questions, this would be a good time to post them and we can address them in a few minutes. I know you're not really used to posting from those places questions, but we will take them and hope that the system is working to fill them through. So what's coming next? So we've talked about where we are, what we've done, and we all know that genetic therapy has come to HCM. Not only did we have the first patient dosed in October, but the second patient has been dosed, and I believe the third patient is right on the precipice, if not already done. So what does this mean? And
Yeah, I,
this is
I,
tough.
yeah, I actually would change the way you presented that. I don't think genetic therapy has come to HCM. I think genetic testing is being investigated in HCM to see if there is any validity or viability to it. And I use those words carefully because we don't know what the impact of delivering modified gene vectors to individual patients is going to be. So to say it's come to HCM, I don't want anyone to falsely think, oh, I should raise my hand and go get my gene. It's a long ways from that. It's a very early phase of investigating the safety of delivering these gene-specific therapies.
I would agree. It has come to us for a clinical trial. And trials, we've had some good experience lately in HCM in clinical trials, and we may then have a bit of a false sense of security that trial means we're going to get to the label.
Exactly. Yeah.
It's a long road.
If you think about the number of clinical trials on anticoagulants that were supposed to be the next thing better than warfarin, there was decades of failed trials before we got to dabigatran, and then apixaban and Xarelto, to use the trade names. But there was, so drug trials, we shouldn't, just because we're excited about them in HCM and we've had success with the recent trials, it doesn't mean automatic delivery of new therapy to HCM patients. It could be, oh, that was a swing and a miss. That drug will never make it to market. It should never be used in a patient, for instance. So we just have to make sure that we understand that's why clinical trials are done. It's just not to prove how much it should cost, is to prove whether there's any safety issues and efficacy issues.
And the concept of delivering gene therapy to a particular organ, and in this case, your heart, it's pretty awesome in that it's got potential and it's got risk.
Yep.
And awesome could be awesomely good or awesomely bad. But it's big. So I think your cautionary tone is absolutely appropriate. I share it. But we are here. It's not just gene therapy for hypertrophic cardiomyopathy that's evolving. We have the Duchenne's muscular dystrophy. We have sickle cell. We have cystic fibrosis. There are other diseases that they're looking at this approach to, and caution is definitely needed. But what should we be looking for at this point? What is the first sign that we're on the path or we're not on the path? Do we even know what that is yet?
I don't think we know what that is yet. I mean, the next big signal that we'll get is when they actually start a larger trial, because again, the current gene therapy trials are limited to a handful of patients, again, to assess for pure safety issues. So that passes that barrier, then the companies that are working in this space will then design larger phase 1 trials, and dose finding trials, and then phase 2 and phase 3 trials. So there's a long pathway here, with stage gates that the companies go through before and some of it's if the results are promising enough for them to invest more money in that therapy.
So right now, the therapies that are being tested, and that there's an open phase 1 and one coming in a couple of months, they are AAV9 therapies. They're not editing. Can you just give a very brief explanation of what an AAV9 versus editing is in podcast language? He's giving me this look like, Lisa, you didn't tell me we were going here.
Yeah, you totally have going to catch me out, and all the people who are watching who are actually in the basic science world are going to cringe. So, but really, it's trying to deliver a whole gene using a virus as the method by which it gets into the cells. So we're actually infecting people with an adenovirus, which happens to be tied to a myosin binding protein C gene.
And that sounds really easy, but it's really complicated.
It's super. It's yeah, and people will they'll feel ill from that. They will, they're getting viral.
So you feel sick, you feel like you're getting a virus, you are getting a virus, and then you recover. And like when we recover from any virus, it leaves a residue behind.
Right. Yeah. So does the body, take up that normal gene or not?
And we hope it does. So
Yeah.
we don't know. So editing is a whole different process. That's removing and then returning information into the body, correct?
Well, I mean, that's my understanding. It's really outside of my expertise. I'm way downstream to once people have proven this is effective and trying to help patients understand if we're going to use it. So
We'll bow out on that one.
Yeah, I will punt on talking about the specifics there.
Completely understood. Figuring it's genetics as a topic, we'll touch on all the crazy stuff and the new stuff. So we will be adding more content and more conversations about these topics over the coming months and years, because it's going to evolve. I don't know where it's going to land, but it's going to evolve. I mean, I will take a moment and go into left field evolution of healthcare. Our friends over at NYU put in an LVAD and a pig kidney a couple of weeks ago, and that's just making news right now. So we are using xenotransplants, so organs developed in pigs and then put into humans. Technology is moving pretty fast, and it's not unexpected to see things move even faster in the genetic realm. Exome transplant, or I said that wrong, not exome. Xenotransplants. We are going into some pretty crazy technology coming forward. So we're going to have to start keeping up with it and making sure that patients can decide what trials might be good for them. And I guess I'm a little excited about the pig kidney. It happened to a woman from Jersey. So Jersey's on the map again, leading technology. And because of all of the great work that all of our scientists are doing, we're able to provide more therapies to more people, and they're getting really advanced. So what else should patients and families know about their heart health history that is really important for you, a clinician, to know about them so that you can provide the best services and treatment to their heart? Is there anything else they should be telling you?
Yeah, that's a great question. So I think that people should be aware of, well, one thing that people often say, well, grandma died at age 50 of a heart attack. For cardiologists, cardiology, NPs and PAs, a heart attack is when a blood clot forms in a coronary artery and stops blood flow, and it can lead to sudden death. That'd be pretty uncommon in a 50-year-old woman. Not impossible, but uncommon in a woman to die of a heart attack at age 50, particularly in the modern era. A cardiac arrest we don't call a heart attack. And so if there's any way that we can get information on the history of the relative, the ancestor who died, were they known to have coronary artery disease? Did they have hypertension, hyperlipidemia, type 2 diabetes, all those kind of things that make coronary death more likely than arrhythmogenic HCM death? It helps in doing some of that risk assessment. But just knowing some of those other conditions that you have, there been fainting episodes in family members. The car wreck that someone had when they were the driver of a car, that may have been a fainting episode from HCM, and which is relevant to the context we're having here. So there's just those types of things are important.
So I think back to stories that my grandmother would tell me about my grandfather. So he was never diagnosed with anything other than a heart murmur and told to avoid caffeine, so he drank Postum. I don't know if you've ever had Postum. It's pretty awful. It's like Ovaltine and coffee had a baby, and it was the non-caffeinated drink of the morning back in the 40s.
Okay.
So he had to move to Postum from coffee because he would feel his heart beating too hard. So family stories can sometimes be more informative than what a medical professional said was cause of death without an autopsy. Sometimes I find that patients hear the first thing that the paramedic says, looks
Yeah.
like an aneurysm, looks like a stroke, looks like a heart attack, but there's no clinical backing to that. It was just what an EMT said, and they believe that to be the diagnosis. So
Yeah.
look for reasons, look at the details, and get as much family history as you can, and keep it in a safe place, and pass it along to your children and your siblings, and make sure that your family history is clearly delineated and explained to everybody who has a potential genetic pathway. I just did a podcast earlier that'll drop in about a week or so with a woman who lives in Atlanta, Georgia. Her brother died in his early 30s from diagnosed HCM, but not managed HCM. He
Mhm.
didn't have the workup he needed. And she brought up a really good point that she grew up in a single parent home. She didn't have a relationship with the paternal side of her family. And now she's finally reaching out to them and learning about what heart history is on that side of the family. And a lot of things are opening up. And there's a lot of reasons that things happened, but
Yep.
nobody communicated about, because we don't talk about the dead.
Yep.
We don't talk about scary things. We got to talk about scary things so we can avoid the dead people. This is the goal.
Yes.
We want people to live. So how do we have those tough conversations when families are fractured? I don't pretend to have the answers to
Yeah,
that.
it's really hard, particularly, I mean, if families are no longer whole in their original nuclear thing because of interpersonal conflicts. But I think you won't get the information shared if you don't try. And so being told, no, I'm not going to give you the information, my family's better than I never asked. Now, again, there are individual variations in fractured families, and maybe it's just impossible. It's going to create more toxicity in that family. So we have to be cognizant that, again, there's different family circumstances that need to be taken into consideration. But it is difficult.
So one of the things we did here legislatively in the state of New Jersey was we added family heart health history to the well child exam. And this is an effort we're trying to take across the country right now. But one of the questions we asked to be added was, is the child a product of egg or sperm donation? To clearly delineate that I don't know that other side of the biologic background, because they may not have ever been given that information, but it also allows an opportunity for frank communication about somebody's biologic beginnings.
Yeah.
Okay. Not everybody knows who their daddy is. We're pretty sure of who the moms are, but sometimes paternity is questionable. And we've had some interesting stories where we've helped counsel families on how to get screening in those situations. So they're real, they happen. Pretending they don't exist doesn't help anybody. I come from a family that learned that my mother had a sister, and my mother found this out when she was almost 40 years old because grandpa didn't talk about his past.
Mm-hmm.
So sometimes we have parts of our family tree that are hanging out there. When you become aware of them, share the information. If you're not sure, talk to your doctor about what screening might be appropriate for you. This goes beyond cardiac disease, goes into cancer screenings, etc. But if you don't know your family history, talk to your clinical providers to find out how you should proceed. Reasonable?
Yep, very reasonable.
Okay. See, we can talk about tough things. We won't talk about politics, though, because that's just too tough these days.
Yep.
Okay. So we don't have any questions coming from the sources that we have today because our Facebook chatty community isn't on today.
Okay.
So we are going to give Dr. Ommen back 15 minutes of his day because he looks really busy this week. So we're going to let him go. We thank you all for joining us for another edition of Tales from the Heart, a podcast from the HCMA. And thanks to Dr. Ommen and all of our good friends at Mayo for all the great things that they bring to our patient community.
Thanks, Lisa.
Thank you. And stream.